Okay, well, thank you. It's very grateful to be here today, the opportunity of presenting to this esteemed group. And I really appreciate the fact that we have a conference like this. I think it's really, really neat. Appreciate all those who make that possible. This gives you some indication of contrast sensitivity again in the real world. There actually is not one mountain here. There are 5 peaks you can see along the way. If you can have, that's the kind of detail you appreciate to a greater degree when your contrast sensitivity has been enhanced. So these are my financial disclosures here. This is the clinic where I live. This is my kingdom, basically where I see patients, and I am the trenches. We have a primary EyeCare practice there in Indiana and do a lot of different things, but the focus has more and more shifted toward doing nutritional counseling. I can say that early in my career, I really didn't ask patients about their diet. I did not talk about ocular nutrition at all, but that has changed, and it's changed dramatically. As I begin to see some of the studies that have come out, things that like Jim has talked about in regard to eye health and nutrition, visual performance and nutrition, that was very intriguing. Some of the studies that have influenced me, I'll be referring to briefly in my lecture here today. But as we looked at those things, that's made a profound way in the way I practice, and you'll see some evidences of those things here today. So I think it's important, why was there a big change and what kind of impact has that really had? I'll tell you a story about Jenny. Jenny is a 23-year-old patient who came in and seemed to be very healthy, had a little bit of history of migraines, otherwise really no problem. But she complained of chronic glare and poor night vision. So I'm looking very carefully at her eyes. I'm assessing, is there something going on here with something unusual? But there wasn't. Her cornea was pristine. She had great optics in her eye. She had very healthy maculas and clear lenses. Everything looked great. Found a slight change in her prescription, which got her being a little nearsighted to better than 20/20 in each eye. Prescribed new glasses. And then you think, well, that's probably going to take care of her problem. But unfortunately, even with those great glasses, with digital design lenses and enhanced design there, she still had the same problem. So in the past, what we would do would be scratch her head, assure her she's fine, she's got better than 20/20, and send her on her way. Because after all, we've done everything we can for her. Or have we? So that's why I'll come back to that. Hold that thought for just a few minutes. If we look at some of the goals as I practice, my philosophy is really to enhance the quality of my patient's life. We're going to use passion for eye care with latest scientific research here to try to enhance the health of our patients' eyes, the quality of their vision. And we do that in order for us to see how patients understand how they and what help they need. We have to understand how they see, and it's important for us to measure those the vision properly. Then we can, once we have that data, we can analyze it, we can use nutrition, we can use other interventions as indicated to enhance our vision. The result, we hope, is better patient care and better visual outcomes. That's what we're after here. So in doing, and as I'll mention here, some of the ways I've developed within my office to start testing contrast sensitivity routinely. So in the past, where I didn't measure it on anybody or really talk about nutrition, it's made such a change in my practice that now I measure contrast sensitivity on every patient and typically have discussions of nutrition pretty much with an overwhelming majority of every exam I do. So that has gone really full circle here, or really turned around 180 degrees. These are some of the diagnoses. Across about 12 different diagnoses, and using contrast sensitivity, I have gained valuable information that has changed what I'm recommending and how I'm intervening for my patients. And so I have about 40 cases I've developed. If I had 25 hours instead of 25 minutes, I could give them all. But I'm going to focus just on a few here today. But basically, I think understanding, I've been surprised at some of the things I found, some asymmetries between the two eyes that I had to explain, and as a challenge. So when you put on your hat, figure what's going on here. There's something under the surface. So I really do think testing contrast sensitivity in my clinic has made me a better clinician, and it's helped me find things that I otherwise would likely have missed. Jim has done a great job of talking about the weaknesses of visual acuity. They're important. But they don't really predict, again, the ability for us to function in activities of daily living. There are definitely limitations, even when done well with equally legible letters, properly calibrated. Again, this 9% that Jim mentioned, I think, is very pertinent. So, we're talking over 90% that we're not really assessing if we only do look at a dark black letter on a white background. There's a lot more to vision than that for sure. So contrast sensitivity helps us measure that border between the visible and the invisible, being able to detect edges and borders again here. So the minimum difference between the luminance of a target, the background required to recognize the target, that's the contrast sensitivity threshold, and the reciprocal, of course, is the contrast sensitivity. In my office, I measure photopic contrast sensitivity. The room lights are out. It's a very dim setting, so we're not talking about the room lights. We're talking about the background around the target. And it's specified at certain luminance levels that should be properly done. And of course, the mesopic is also possible where you make the background very dim. Unfortunately, that normally requires about a 30-minute dark adaptation, so that doesn't happen in my office. But we can measure the letter contrast sensitivities with photopic quite easily and quite quickly. So why is that important? Because in the real world, there are lots of low contrast situations. If you go down these steps here, someone has been smart and put some white strips there along the top of the edge of the step. But if you take those away and your contrast sensitivity is poor and the light's poor, you can see how easily it would be to just trip and to fall right down the steps. Looking on the way to Alaska, actually looking out my airplane window coming into Chicago this last February, this is what I saw. I took a picture of it and I started thinking, wow, that's a great example. That doesn't really look like dark black on white background at all. To appreciate the beauty of that scene, you see these low levels of contrast and subtle differences in the gray here that really help you understand what was going on there, what's really present. So again, Jim mentioned contrast sensitive function, sensitivity. So if you take targets, let's say about 5 different spatial frequencies that cross. So what we're really again representing here is things that are becoming fainter, things that are becoming smaller. So down here is the part of the curve, again, where we're looking at visual acuities. But what we really want to know in terms of visual performance is what's happening up here. And things, you can think of it as diseases like poor nutrition and cataracts and macular degeneration and glaucoma and other things are trying to push that curve down. And as eye care providers, I want to lift it up and make it really high as I can, and I can do that through various means. And of course, if that line flattens, we have blindness, which we don't want. We want to expand the width of the visible world for our patients here. So again, this is something that spending all our time here is not really what we should be doing. And again, this size of target is, again, right at that 2100 or 6 cycles per degree. This is using, again, sine waves, but we can also convert to letters. And don't spend a whole lot of time on the math, but the 20, 30 cycles per degree translates into the 2100 size 6 CPD that we really want to look at and measure on a routine basis here. And again, that's important because this 2020 or 2100 or 630 letter or 6 CPD is the best target size to understand if you're going to really predict how the patient's going to function and being able to see a scene, an object to face, a target of various kinds. So we can do that now efficiently, and the Pillay-Robson test from 1988 would be kind of the gold standard in the past, but there are some limitations to using physical charts. We can take an electronic LCD and do these tests very efficiently in our practice just at the end of the exam. And again, there was a comparison study from 2003 Journal of Ophthalmology that showed similar results between the two tests, and this was for across different ages and different diseases, normal and diseased eyes both. So now we can do a rapid assessment of contrast sensitivity with this electronic measure, and that makes it much more doable, much more efficient in the practice. So this is my protocol. So basically we're taking about a 2100 letter and we're making it fainter in certain steps until it disappears, and it's done one eye at a time. The pupils need to be non-dilated, and it's just a normal sized pupil. If you dilate your patient before you do this, it's going to have a significant impact in a negative way on their contrast sensitivity. And you can record the lowest level, which they can correctly identify 2 or 3 random Sloan letters. And you can record that information It takes about a minute per eye to do so. So it's not a big investment in time, but it's giving me, again, very essential information to how the patient really sees. So what's normal? If we're going to measure this, we have to know what's normal and what's not. So we can look at the various studies here that have been done, and various standards and baselines that have been done in various studies. But basically, when no ocular pathology is present, clinical studies experience suggests that for the 630 or 2100 letter, the expected contrast sensitivity, an average reading would be 2 to 2.5% based on depending on your age. And so that's what we're kind of looking at as average. So I've created an action diagram. If you look over to the left, I really tried just to make it easy here. So yes, if the eye health is normal, there's no disease that's having an impact on contrast sensitivity that we can identify. Again, we have this average, we have the good levels here, we have poor, and again, based on ages of up to 60 and above 60, about a step difference here. These are 0.1 logarithmic steps, again, so green, good, yellow, average, kind of borderline here, and then definitely impaired down here. 4% would be the level at which we'd start to call it impairment. So that's a quick and easy way, and I'm going to have that little key as I give some cases here in a moment along the left for the whole lecture, so you'll be able to not have to memorize it. You can just look over there and see the norms there. So again, the slide that Jim showed, again, these are patients in my practice from 0.8 to 8%, 20/20 or 20/20 minus vision. So you simply cannot predict the patient's contrast sensitivity from their visual acuity. And that's, I think, important thing to know. I only have one patient in my practice who's been able to do better than 0.8. One patient can do 0.6, so she has extremely good contrast sensitivity. But 0.8% is a difficult thing to achieve on the test. So again, when we hit the 6.3, we would be thinking about referrals for cataract surgery if that's the main problem. So poor, if you have good visual acuity and poor contrast sensitivity, it's still very poor quality vision. This is basically a chart that helps us understand the visual impact of what we're doing here. If we take a patient and we're improving contrast sensitivity, how much is that really affecting their world? So we can compare the visual impact of being able to identify a letter one step fainter on the contrast sensitivity chart. Can compare that to the ability to identify letters one line smaller on the VA chart when both are measured in an equal logarithmic increment here. So for instance, a patient who comes in and you've measured 2.5% and you intervene and you get them to 1.6%, you can think of that as a similar impact, or at least as much of an impact, as taking a patient who's 20/30, 20/32, doing something, maybe you change their glasses and you get them up to 20/20. I think all clinicians, if I have a patient who comes in and I can make them see 2 letters on the visual acuity chart by changing their glasses, I'll recommend that. I think that's significant. And I think it equally or more so, we have the impact on their visual function when we improve contrast sensitivity. So these are some of the studies, again, that I'm going to talk about here briefly that have impacted. So if we find a patient who has what looks like normal, healthy eyes, visual acuity is 20/20, their contrast sensitivity is poor, what do we do? Do we have science to support what we're doing? So again, the CRUST normal trial that was published a couple years ago on OVS, using the supplement with 10 milligrams of lutein, 10 milligrams of zeaxanthin, and 2 milligrams of zeaxanthin over a course of a year, a statistically significant improvement occurred right here in this 2100, the 6 CPD area for those in the active study group. And I think that's very significant, whereas the placebo, there was no change. Again, the average baseline letter contrast sensitivity was 2 to 2.1%. So you don't have to just think about offering this kind of supplementation for those with very poor contrast sensitivity. Even if it's average, those patients can still benefit. So what's going on here? Why is it, again, and Jim's made such a nice presentation, but we do know our macular carotenoid pigmentation, or average intake is very low in the US, less than 2 milligrams. I think that's true in the UK as well, much too low. Unfortunately, about 25% of the vegetable intake in the US consists of French fries. Says a lot about our diet and fast food, doesn't it? And even studies that show perhaps the nutritional content, the density, if you will, of our foods currently, even the healthy foods, is less than it used to be due to the effects of intensive farming. So again, how well are we enhancing these pigments, the lutein, the zeaxanthin, the meso, across the retina? There's room for improvement for many, many of our patients that walk in. And if we don't measure contrast sensitivity, we miss an opportunity to talk to them about it. This is kind of a follow-up on the question that was just asked. These graphs are courtesy here of John Nolan. So you can have a very central macular pigment can be high, but the question is, do you have a church steeple? It's not what you want. You want a nice broad mountain with good macular pigment volume here. And so you can't be misled. Normally, I think if a patient has low central pigment, I would think they probably have a low pigment volume. But if they have a high number here, don't just assume that they have good macular pigment volume, which is really the key there. So we're back to Jenny now. So again, these are the photographs of the back of her eye. She sees better than 20/20, slightly nearsighted. Again, she has new glasses. It doesn't fix her problem. Now what do? We have a patient who's unhappy. Well, what can we measure? We can measure her contrast sensitivity. And sure enough, we did that. And it was 3.2. Now, how's she doing? So we look over here. Well, she's definitely, for her age, she's definitely not in the best place. These are images of barometry, which basically shows she has a very good visual system in play here. So excellent optics, but a history of very poor diet in the last few years. Her pigment optical density is low. So we supplemented her with the 10-10-2 triple carotenoid, and she came back in 8 weeks later. And really, I was somewhat skeptical of this, but I checked it and rechecked it myself, and she had a significant improvement in her contrast sensitivity, up 3 to 4 lines on our chart. Again, she's a healthy young lady. She told me she set her phone. She was very compliant. She took it every single day. She did not miss one. And so we see slight improvements in her MPOD, but importantly, when I asked her, Jenny, how much improvement are you really seeing here? One's just a little bit, let's say 1 to 10, and 10's an awesome improvement. How much improvement do you have? And she gave it a 6. And I think for 8 weeks of supplementation, that's fantastic. And then she came back again for a follow-up at 3 months, and we got exactly the same numbers, 1.25 and 1.6. So this kind of impact on her, reducing her glare, is something we really need to be aware of and do. So again, if we think of her back in her early years, she did have a very good diet when she was growing up, exposure to lots of healthy nutrition. She came to the United States, poor diet in college, no longer ate vegetables. And so again, I think the whole concept of patients with normal visual acuity, no eye disease, often we can leave these special problems unaddressed if we overlook the importance of ocular nutrition. So this is just an observation. This patient came at about the same time as Jenny, and she was also similar, about the same prescription, good acuity, but a very healthy diet, excellent MPOD. We measured at 0.76. She's a pescatarian here. Her contrast sensitivity was 1.6. Her numbers on aberrometry in the cornea actually mimic Jenny's quite closely. So just an observation here. And then we have a couple of patients here I want to compare for you. Paula is very compliant. She's a 59-year-old Caucasian female who presented for an examination. She comes and sees me every May. She's extremely compliant. She has visual acuity that's excellent. Nothing really significant in terms of her eye health. A little bit of dryness. She's on medication for cholesterol and hypertension. She also takes a triglyceride form fish oil faithfully every day. But we started her on a triple carotenoid supplement 4 years ago, and she's, again, very, very compliant with it. So I think these graphs, this is not what I see every single time, but she's had an amazing march upward in her pigment level. From 0.34 before she started supplementing, every year she shows this improvement. Started measuring her contrast sensitivity in 2017. Her MPOD was 0.7 centrally here again, but she was 2% average, and she continued taking it. This year she's almost to 0.8, and she has improved by 2 lines on the contrast sensitivity chart. So I think that's interesting. She's made a huge improvement there. Now let's look at Patty, second patient here. She's also a little bit younger, 47-year-old Caucasian female. She's also very faithful in her exams, comes to see me every June. She's had 20/20 acuity no pathology. She's had some recent diagnoses. One thing I think is kind of interesting is she has this irritable bowel syndrome. She's lost 30 pounds. She came in just recently and looked at her, and I noticed she looked thinner. She wasn't trying to lose weight, but she has something going on systemically here. But she's also on tamoxifen for breast cancer, no history of any toxicity. She's never supplemented. Here are her graphs here. So her MPOD was variable a bit here, but in 2016 it was above 0.8. But the last 2 years she's on a downward trend. And interestingly, as I measured her MPOD and her contrast sensitivity last year, she was at 1%. And this year, after her systemic things, whatever is going on, her pigment levels are dropping, and now she's at 2%. She's lost 3 lines here on the chart. So I think that's an interesting thing. So now she is actually supplementing. So here's the comparison between the two, so going in different ways. And so I think that's an interesting clinical observation. If we talk about contrast sensitivity, it's also reduced in other things. It is nonspecific, but it helps us understand the visual impact of various diseases on the eye, things like cataract, very important and helpful, macular degeneration, other things as well. We can figure out how our patients are really seeing when we have this tool to use in our office. This slide, 50 consecutive patients. 90% of them were 20/20 or 20/20 minus or better. And yet, of those patients, 70%, almost 68% of them were either average or poor or impaired in their contrast sensitivity. So we don't really understand how our patients are seeing if we don't take the time to do contrast sensitivity measurement. So there's an unmet need out there. And if we don't measure their contrast sensitivity thresholds, we're going to miss identifying those patients. So if we think about visual impairment, how we define it based on some information here from NCBI, if we say 4%, that's patients is 4% contrast sensitivity threshold, that's likely to influence or impact them in a negative way significantly. If they're at 10%, that's going to be severe visual impairment. That's a 10-fold reduction in contrast sensitivity versus an ideal, let's say, of 1%. So this was one of the other studies, the MOST trial, published in 2015 here for AMD. Thank you, 3 minutes. So after 36 months, we see 2 lines of improvement here. We see improvements both in contrast sensitivity at 6 CPD and also the change in pigment there that corresponds to it. And these, again, are patients who have disease. They're getting older, so you'd think these patients are going to be potentially getting worse in their vision. And they improved by 2 lines. I think that's very significant. And of course, the CREST AMD trial more recently published 2 groups, both with an ARIDS formula with lower zinc. One group had the 10 milligrams of mesozeaxanthin as well. And 75% of the vision-related outcome measures in both groups improved. Again, I think that's very significant. Those with the meso, a greater percentage of those patients showed improvements in contrast sensitivity. This is a patient here in my office, again, Myra. She's 67. She has bad disease over here. She's had injections. She's seen about 20/40 to 20/60. Looking at her photographs, you can see that she has AMD in both eyes. This is intermediate. How's this patient really seeing? Her visual acuity is 20/25 plus and 20/40 minus. Here's a fundus autofluorescence view. This eye, again, very, very poor, very severely impacted. But look at her right eye. She's at 2%. And she's got glaucoma too. You can see the optic nerve here, the cupping. She's got a little bit of cataract. She's got intermediate AMD, but she's been supplementing. Her MPOD has been going higher here for the last few years as we've supplemented her, and she's at 2%, which I think is remarkably good and evidence, I think, of what's happening here with the nutrition. And then finally, in cataract, I found this to be a very useful tool. So as with the age of the population, we're around 1 billion people now, 60 and above, heading to 2 million or 2 billion by 2050. Rates of cataracts in the United States going higher and higher. So the role of nutrition in cataracts, lutein and zeaxanthin are the only carotenoids found in the lens. ARIDS 2 showed no overall effect unless you looked at those with the lowest dietary levels of carotenoids. In that group, there was a 30% reduction in cataract development and 36% of severe cataracts. So this is a patient here. Again, that's important because of the risk for accidents as contrast sensitivity declines. Again, our guidelines here, intervention needed as contrast sensitivity reduces. But this patient had 20/20 vision. in this eye, 20/25 there, and you look at this patient and you think, does this patient need cataract surgery or not? And sometimes it's easy and sometimes it's difficult. This would be a tough one for a lot of people to decide because of the 20/20 vision. But when we measure contrast sensitivity, it becomes a very easy decision. He's significantly impaired. He's got symptoms. He is not seeing well at all. And so after surgery, remarkable improvements, 2%, 2.5. This patient's a happy patient. He's very happy. And there's improvement potential for his vision to continue to improve. You can see his MPOD scores have risen very nicely over a period of 8 months with carotenoid supplementations. We're trying to reduce the oxidative stress because he's getting childhood levels of blue light now hitting his macula. So I think it makes sense for these pseudophakics to be supplemented as well. So the learning continues. These cases are ongoing. These are patients in my practice. I continue to learn as I do this and see the improvements in visual performance. So thank you very much.
Thank you. This paper is now open for some questions. Yeah, up the front. Ute.
Thank you very much. It's wonderful to hear that. What I'm thinking about is, why does it take so long to enrich the macula, to increase the macular pigment density? Could a higher dosage have a faster effect? Or why does it take a year or up to 4 years to really, in this one patient, to double or triple the amount?
Yeah, I think if you take it on a regular basis, everybody again has, I think, genetic differences, other things that, how will they absorb things, what else is in their diet. I think there's lots of factors. I think that kind of improvement, that steady march upward, I think we're enhancing the pigment. It takes a little while to build it. I just think the absorption there. I think it is interesting that the younger patient that we saw, she had remarkable improvements in her function, and I think we're looking at the improvements of neurophysiology because, again, as Jim mentioned, we have these macular carotenoids in the entire visual system from the eye to the brain, except for the shell of the eye, cornea, sclera, maybe the vitreous. So when she was taken, I believe she was enhancing the neurophysiology of her retina throughout in ways that weren't reflected just in measuring her MPOD. So I think we're doing more than we realize we're doing, even if our levels of MPOD may not be rapidly rising as quickly as we'd like to see in some cases.
I think Paul Bernstein may allude to some of the, the binding proteins and the biological turnover. He might make reference to that, but it's an important question. Rebecca, have we another question? Yes, at the back, yes.
I have a practical question. How do you talk to your patients about this testing? You just do it on every patient or just on patients who complain, or do you offer a package, or they just come to you because you're an expert?
Well, let's see. So what I do is I don't give the patient the option any more than I would. I think contrast sensitivity testing should be part and parcel of our routine care. We don't really have a special code within our system for doing it. I don't think we need one, unless we have one for visual acuities. Do we have one? No, it's just part of our exam. So I think it should be, what I do is I simply do the refraction while the phoropter is still in place. I turn the lights out, I isolate the letter, I've got their best vision at play, and I do the test. Again, it takes an extra minute. What it does, it allows me then, once I've done that test and I pull the phoropter away, I start talking to the patient, mentioning, this is a test you probably never have done before, but it's very important for us to understand that, to know how you're really seeing, because most things aren't small black on a white background. And patients get that when you start talking to them about that. So I've incorporated that discussion. It has opened the door then to talk to them about macular nutrition. If they're average, if they're symptomatic, they're very open to it. Some patients have adapted, it seems, and even if their contrast is only average, they don't necessarily have symptoms, but I still mention it to them. And if I then have done, let's say, a pigment score with the densitometer and it's low 2, then we talk about reasons we want to enhance the pigment for the protection of their eyes, reduction of disease long term, reducing the risk at least, and certainly helping enhance their visual performance, which is, I think, a discussion they're not used to. But I'm just doing that routinely and trying to encourage other optometrists in the U.S. to do that as well.
Thank you. Very interesting talk. How many of your patients are open to, let's say, a nutritional change of their diet, or do you go straight ahead with giving or prescribing tablets or supplements? So kind of like, how many of your patients are open to changing their diet, which is kind of like really hard to do, or they're kind of like more or less just looking for the easy way out, which is taking a tablet?
Right. I think it varies a lot. If they're symptomatic, if they have like some glare at night, things like that, the discussion is easy to convince them that, we have evidence that this could help for you. I do talk about their diet. I commonly mention, I probably say the words spinach, kale, and orange bell peppers several times a day to my patients and encourage them. And I've had patients come back later who actually have started using spinach in their smoothies in the morning and things like that. So we have made some impact there. But I think many patients, because it's so hard to change what people do in their habits in terms of their diet, I think adding this supplement to their diet does make sense. And by and large, many of them are open to that if you explain the benefits.
So I think we're ready for our next speaker. Thank you so much.
Okay. Thank you.